putting the disclaimer up now.
Good afternoon, everyone. Welcome today to St. John's Riverside Hospital's next webinar, Exciting Trends in Breast Cancer Treatment. Before we begin, I would like to take a moment to thank my team, Nancy Nabi and Candace Cousins-Hopkins, along with Olivia Hunter, who put the whole thing together and promote it, as well as our IT team, Jason Latour and Mike Matalal, who make sure that we have no glitches. And when they do happen, they take care of them and make us all very comfortable. So before we get going, I would like to take a moment and introduce our speaker today. Oh, before I do that, let me just say this. I'd like to acknowledge our community partners. Sally Pinto from the Yonkers Neighborhood Naturally Occurring Retirement Community that is under the umbrella of the Yonkers Office for the Aging, and Westchester Jewish Community Services, and Z Baird, who is from the Yonkers Public Library, and we appreciate their support and their help in getting the word out to the community that we hold these educational programs. Okay, so now right to our speaker introduction. Maureen McEvoy, MD, is a breast surgeon at Montefiore, as she is an assistant professor at the Albert Einstein College of Medicine and the program director of the Breast Surgery Fellowship. Since 2015, Dr. McEvoy has been devoted solely to caring for women and men with breast cancer. Her clinical focus is on minimally invasive and oncoplastic techniques to achieve cosmetically acceptable outcomes while treating breast cancer surgically. Additionally, she educates her patients about their diagnosis and helps them explore treatment options. In 2002, Dr. McEvoy received her Bachelor of Arts in Mathematics and Chemistry at New York University. She continued her studies at Albert Einstein College of Medicine, where she received her Doctor of Medicine in 2007. Her postgraduate training began in 2007 at Albert Einstein College of Medicine with a surgical residency, which she completed in 2014. In 2011, she completed a clinical research fellowship at Memorial Sloan Kettering Cancer Center. Her training continued at Massachusetts General Hospital in 2014 with a year-long fellowship in breast surgical oncology. Speaking on behalf of the entire St. John's Riverside community, we are very pleased to welcome Dr. McEvoy to our community of outstanding physicians, and we thank her for her participation today and in many of the programs that she has done so far this month. So without further ado, I'm going to turn it over to Dr. McEvoy.
Great, thank you for that introduction, Denise, and thank you everyone for attending this today. I'm going to go ahead and open up my presentation. Okay, and can we see my screen? Great. Okay. Well, like Denise said, I am excited to be here today. Giving you a talk. I'm going to focus on new things that are happening in breast cancer treatment. Sort of give a little bit of an overview of what to expect when you have this diagnosis, or friends or family who are going through this. What my role is as a breast surgeon, and how we get to go through the diagnosis and get beyond it. Breast cancer is common. 1 in 8 women will get breast cancer in their lifetime. The statistics for this year are that we see about 281,000 new cases of invasive breast cancer here in the United States. Our non-invasive breast cancer, which is stage 0 breast cancer, we see about 50,000 new cases a year. About 43,000 patients will die of breast cancer in a year. However, we have 3.8 million breast cancer survivors. So what's important to sort of know about this, that while it is a common thing that we see, patients do well, and we have a tremendous amount of patients who are able to get past this. The survival rates for breast cancer in general, a favorable breast cancer that's been caught early, if localized, meaning if it's just in the breast, the survival rates are excellent. Regional breast cancer, meaning that perhaps it has spread to the lymph nodes under the arm, the survival is greater than 85%, which is still very, very good. And one of the main reasons that we see such good outcomes, such long survival rates, is because we have a very good way of detecting breast cancer before it becomes advanced. So by having a screening program using mammograms, we are able to catch breast cancer at a point where it's early and where we can actually cure it. We believe that screening should be done starting at the age of 40. There's a lot of different guidelines in terms of when to start screening mammograms. And we believe that it's best to do it at the age of 40. This is based on data that shows that patients do get breast cancer at an early age, and it does change outcome. People always ask, when should they stop screening for breast cancer? And the most easiest way to sort of determine when it's good to stop would be when someone's life expectancy is less than 10 years, as opposed to actually giving like an age cutoff. When patients get to the age of 75 or older, you can consider doing mammograms every other year, as opposed to every year. And when you go to get your imaging, you should definitely ask for a 3D mammogram. That's a tomosynthesis, or you can call it 3D mammogram. And it is, it's a more detailed test, and it definitely has been proven to pick up smaller cancers. So what is my role in a patient who gets a breast cancer diagnosis? So typically, patients will go for their screening mammogram, and they will be found to have something an abnormality on that screening mammogram. They're called back for additional imaging and eventually will undergo a biopsy. And perhaps their primary care doctor or the radiologist will call the patient and say, I'm so sorry, but we have found that you have a breast cancer. They refer the patient to see me as a breast surgeon. So when I meet the patient, I'm typically the first person who sits down with them and goes over their diagnosis. One of the most important things that I want to do is, build a strong relationship. I'll have a long follow-up with my patients, getting them ready for the operating room, bringing them to surgery, and then seeing them afterwards for several years. So that initial bond, that initial relationship, making the patients feel comfortable, and really giving them a sense of understanding of what this diagnosis means. I spend a lot of time going over what is breast cancer and educating the patients on their options. I really enjoy speaking to the patients, helping them through this difficult time, and really seeing sort of a transformation in their body language and in their face as they come in very tense and obviously upset, and are able to then leave the visit with a sense of plan and a sense of hope. So in general, how do we treat breast cancer? And this is a very simple sort of outline of what you would expect. The order of how these things happen can change. So you may have a family member or a friend or even yourself who went through this treatment, and you can say, well, I actually had chemotherapy first, or someone may say, I didn't need chemotherapy at all. And so the way that we determine, what treatment you need is really specific to the patient and the type of cancer that they have. But in general, we usually need to do all three of these steps. And typically the first step is surgery, bringing the patient to the operating room and removing the tumor. And there are two different ways to remove the tumor. We can simply remove just the tumor and leave the breast as it was. I can rearrange tissue to hide a defect so that it's not as though we've taken out a tremendous amount of tissue. The other option would be to do a mastectomy. And that really should be a conversation with the patient and with the surgeon to determine what is the best fit for the patient and understand the patient's need. Sometimes we can't save the breast if the cancer is in multiple sites or if it's very big, taking over the whole breast. We really do need to remove the whole breast and do the mastectomy. And if that's the case, there are ways to save the skin. There are ways that we can leave the nipple in place and hide the incision underneath the breast. We work very closely with plastic surgery, and during that same surgery, they can come in and reconstruct the breast, whether they put in an implant or use the patient's own tissue, such as their belly, to rebuild the breast. Those are all options, and those are things that would be discussed on that first visit. After surgery, one of the next treatments is radiation. A patient typically needs radiation to kill off any microscopic cells that could have been left behind after surgery. Surgery is great at cutting out a tumor, but it can't individually pick out tiny little cells. So the radiation is a treatment that's given to the breast over a course of time, and it kills off those microscopic cells, dramatically decreasing the risk of recurrence. And finally, the systemic therapy. And what that is a way to protect the body from having a recurrence. So it's one thing to have the breast cancer just in the breast, and that's actually something that we can treat and cure. But once the cancer cells leave the breast and go to other places in the body, such as the lung or the bone or the liver, then it becomes an uncurable situation, and then we need to come up with different options. So to prevent the cancer from spreading to other parts of the body, we offer a systemic therapy. Sometimes it's chemotherapy, which is an IV medicine, and sometimes it can just be a pill, such as an anti-estrogen pill. In terms of our surgical options, like I said, you can choose to have a lumpectomy or a mastectomy in either case. I really strive to provide a nice cosmetic outcome for the patients. As you saw, the survival rates are very high. So patients will be living with this, post-operative breast for the rest of their lives, which we hope will be normal life expectancy. And therefore, how can I plan my surgery so that I don't leave the patient disfigured? I don't want 5 years after the diagnosis for the patients to look in the mirror and constantly be reminded of what they went through. So I try to hide the incision, whether it's underneath the breast in the inframammary fold, or I hide it around the areola. And I can get to any place in the breast from either of these incisions. I don't like to make a cut actually on the breast. I want to hide that scar. And in terms of a mastectomy, like I said, there's different ways to do that, saving the skin, saving the nipple, and working with the plastic surgery team if that's something the patient wants. A lot of times patients ask, maybe they should just remove their breast so that they can live longer. They may have had an aunt or a family member or a friend who they remember didn't remove their breast, and several years later it came back. And so a lot of patients initially come in and say, just do everything, just remove both of my breasts, and that's what I want to do. But we have long-term data, over 20 years of data, to show that the survival, the outcome, is actually the same for both of those surgeries. You don't need to be drastic and remove your breast to be able to survive. By randomizing women, by saying, this group here is going to remove their breast, and this group over here, we're going to save your breast, and following those patients for 20 years and more, we know that there's no difference in recurrence. And that's mainly because patients are not dying from local disease, they're dying from distant disease, meaning when it spreads. And that's treated with that chemotherapy or a pill. So that's what's really making the difference, not necessarily the surgery. So again, you should feel as though you have options. And like I said, in terms of the lumpectomy, we hide that incision and we can take out the tumor. For the mastectomy, if we were to do what's called a skin-sparing mastectomy, that's where we do need to remove the nipple and the areola. We leave all of the skin in place, and the plastic surgery team would then come in and provide reconstruction. and rebuild the nipple and areola. Sometimes patients are afraid to leave any skin, and we tell them that, again, with over 10 years of data, there's no concern about recurrence. When I do a nipple-sparing mastectomy, I hide the incision underneath the patient's breast, so in the inframammary fold. This is a patient day 1 in the hospital after surgery. She had both breasts removed with immediate implant reconstruction. And more than 80% of my patients, if we're able to save the nipple in this circumstance, that's what they're going to choose. Once we've gotten through the surgical piece of it, we do need to then ensure that it doesn't come back, and that's where the radiation helps us. This is typically reserved for patients who just remove the tumors, who have breast conservation, not for patients with a mastectomy. So there are 2 forms of radiation. There's whole breast radiation, which is our much more traditional treatment, and that's depicted in the picture where the patient's lying on the table. The radiation treats the entire breast. That is a very inconvenient, time-consuming process. This is a daily treatment, Monday through Friday, every day, for about 6 weeks. Each treatment only takes 20 minutes. However, the patient needs to come to the breast center, get checked in, go to the exam room, get into their gown, go into the radiation room, get onto the table. And even though the treatment's only 20 minutes, that whole process of checking in and checking out and getting set up is about an hour of their day. So there is a way to decrease that inconvenience in selected patients, and that's by doing just a one-time radiation treatment the day of surgery. So this is the intraoperative radiation. The day that we do the surgery and we remove the tumor, we then place the radiation catheter into the breast, and we deliver about 20 minutes of radiation to that cavity where we just removed the tumor. We then take the cavity out, we close everything as though it's nothing happened, and the patient wakes up and they're all done with surgery and radiation in a one-time setting. Again, this is for select patients, but that criteria has expanded. We have over 10 years of data with the intraoperative radiation, knowing that it's safe, it's effective, the recurrence rates are similar to doing whole breast, and actually the mortality or the survival is improved with the intraoperative radiation. And lastly, this was the 3rd step that we had sort of looked at on that outline, systemic therapy. So this is what really is changing the survival of our patients. Breast cancer patients, when we used to only be able to offer them surgery, did not do so well. And that's because the tumor cells do have the potential to spread and go someplace else. And so by preventing that spread, by targeting the factors that are actually causing the cancer to grow, we're able to prevent spread. So some patients have a breast cancer that's feeding off of estrogen. This is a hormone that we have as females in our body. And if we're able to prevent the estrogen from feeding the cancer cells by giving a pill or possibly by giving chemotherapy, those patients have a great outcome. Some patients' tumors don't care about estrogen. They're not feeding off of estrogen, and those are patients who we refer to as triple negative. All of those patients need chemotherapy because in a sense, we don't really have anything to really target. Those patients all will go on to get chemo. And more recently, we have identified a protein, which is called HER2/neu. And we know that in specific cancers, this can actually be feeding the tumor. And in those patients, we're able to give them an immunotherapy, something that blocks the actual receptor that's feeding this protein. So there's less side effects because it's a very directed treatment. And those patients have an excellent outcome. In terms of individualizing the treatment for each patient, that's something that has really, been able to happen in the past couple of years. This is this concept of taking the tumor from the patient and sending it out for, genomic testing. And what that means is there are ways to look at that tumor and understand what's making it grow, and what rate is it growing at, and how aggressive is that tumor. There's over 20 factors that they will look at in the lab to see, how aggressive that tumor is. And by understanding that individual person's tumor biology, we're able to determine whether or not they would actually benefit from aggressive chemotherapy. Previously, we used to feel as though, all patients with the intermediate grade or higher type of a breast cancer should all get chemotherapy. We felt that that was the right thing to do. However, by now having this, idea of precision medicine, these genomics testing that we can do on the tumors, we've been able to reduce the need for chemotherapy in over 70% of patients. These studies looked at survival, over more than 10 years and found that there was no benefit to chemotherapy. And like I said, over 70% of patients. So now with this excellent genomic testing, we're able to avoid aggressive treatment where it's not needed. And by having the, concept of, de-escalating the surgery and de-escalating treatment by knowing genetic profiling, how can we help patients and not be so aggressive and not be so, causing all of this morbidity for patients who are surviving so long? So we focus on doing less aggressive surgery. We use imaging such as mammogram and ultrasound and breast MRI to really determine the size of the tumor, to get a better sense of the borders. So when we go in, we're much more precisely localizing that tumor and taking out just what we need. We're not removing excess tissue. We're not leaving the patient deformed. We really focus on breast conservation, saving the breast, and doing less mastectomies. Out of my patients with breast cancer, I do less than 30% of mastectomies. And those that I do mastectomies on are because I really have no choice. They have multiple tumors in one breast, or it may just be really patient driven. In terms of, morbidity such as arm swelling, people ask about lymphedema, and you hear about patients who had breast cancer and they have this swollen arm. So we have ways to avoid touching the lymph nodes in women who are older. And we have ways to map out the lymphatics, the drainage of the upper extremity, so that while we're operating, we're identifying the upper extremity lymphatics, and we can avoid those so that we're not causing harm to the arm, and we're really focusing on just the breast. And looking even into the future, and some things that we're actually doing right now, there are some patients who may not need surgery at all. So patients who are older and have very tiny favorable tumors, instead of going to surgery and cutting that tumor out, we can now freeze the tumor. That's an in-office procedure. We place a needle into the tumor, and we have a machine that is able to create basically an ice ball around the tumor, freeze it, and kill off those cells, and the tumor dissolves. It's a scarless procedure, so there's no scar, but more importantly, it doesn't require surgery. It doesn't require anesthesia. For older patients with some comorbidities who may be at an increased risk of surgery, we can safely avoid it. And lastly, this is a study that is currently enrolling, and this is again looking at avoiding surgery altogether in patients regardless of age. And these are for patients who have tumors that we can really target their receptors and what's feeding it by giving them immunotherapy. And perhaps we can just give that upfront treatment, systemic therapy, and in those patients who, based on imaging, have a complete response, instead of going to the operating room, we can just simply do a biopsy again of where that tumor used to be. And if that biopsy shows that there's no tumor there after they've gone through treatment, such as a chemotherapy or an immunotherapy, they can probably avoid surgery altogether. So that's a trial that's ongoing and unrolling, and just sort of an example of how we really are looking to decrease all of the treatments and really try to treat patients based on their tumor biology, and decrease all of the morbidity, the side effects that can come with aggressive treatment. So in conclusion, just to sort of summarize what we spoke about, breast cancer is the second most common cancer in women. There's very, very good survival rates if it's detected early. And luckily, we have a way to detect it early by getting a screening mammogram every year, starting at the age of 40. It's something that you can control. It's something you can do. So many patients, so many people ask, what can I do? I'm terrified. Get a mammogram every year, because if it's caught early, it is an inconvenience, but it is something we can definitely cure. As you saw, hopefully in the webinar, treatment options are expanding, and we're much more patient-centered at this point, really focusing on how can we minimize the treatment to get the patient through this. Thank you.
So, Doctor, there are some questions from the audience, which I'm going to read out to you. And I want to first thank you for that, because I thought that was very enlightening. The first one is the symptoms and possible signs of breast cancer. So let's go to the beginning. I know everyone should get their mammogram, but are there other things that might tip someone off to go ahead and go get it checked out?
Sure, so that's a great question. Typically, we think of any kind of skin changes. If you notice that you may have a newly inverted nipple, or if you have dimpling of the skin. Patients who have a palpable mass, they feel a new mass that they didn't used to feel before. Very rarely, breast pain is associated with breast cancer. However, if you're really having a persistent pain and you were never someone who ever had breast pain, regardless of your menstrual cycle, that would be something to warrant getting checked out.
There's a lot of discussion about, and I know what you said in the presentation, but there's a lot of discussion about what's the right age to start getting a mammo. So what do you say about all of that discussion that's going on?
Yeah, so I think, some of it is not really well data driven when you have, for example, like the US task force suggests age 50 and every other year. And unfortunately, some of that can be really due more to access to care. But I believe that in this, country, with the data that we really do have that shows that mammograms can catch cancers earlier, which will in the end decrease mortality. Patients dying of breast cancer, age 40 every year is what we recommend.
Okay. So there's a lot of discussion recently, and it's been in the news regarding the COVID-19 pandemic and how many people have delayed getting tests. And so I was curious, this is my question actually, is the incidence of breast cancer up this year over 2020 or 2019 based on what we're seeing as a delay of people getting their mammograms?
Sure. I mean, there was I don't necessarily know, to directly answer the question, I wouldn't say that the amount of breast cancer has increased. However, the stage at which we're seeing patients has increased. So we used to catch most of our breast cancers at an early stage that would be treatable. And now we're seeing more patients with advanced disease that is a little bit harder to treat. And that's because of the delay in treatment. A lot of the sites were closed. Patients couldn't get screening mammograms, and they weren't able to come until it was something that they could actually feel, when it had become too late.
Okay, thank you for that. Also, there was a lot of discussion after people had gotten the COVID-19 vaccine that they should delay getting their mammograms based on some swelling. Can you address that?
Sure. So patients, when they're getting their COVID-19 vaccine, on the side that they get it in their arm, we were noticing that they had enlarged lymph nodes when they would then go for their mammogram. And that's actually like a great response, showing that your body, took this vaccine and is fighting it and is generating antibodies to be able to fight COVID. So I actually would be happy to know that you produced antibodies and had an enlarged lymph node. However, it was concerning in the beginning because we were thinking that, what are we seeing? Are we seeing patients with some axillary disease such as breast cancer? So the recommendation is to not to delay getting your mammogram, but if we do see that you have lymph nodes on that mammogram, we then call you back after 3 months and just do an ultrasound of the axilla to see that the lymph nodes have returned to normal.
Okay. A little bit off that topic, question has come in, if there is a strong family history of cancer, and this is, I think, in reference to the genes, what are the odds of getting another cancer, or how does that change the treatment options? Or is there, there's a lot of pieces to this question. Is there opportunity to think about genetic counseling?
Sure. So any patient at this point now who comes in with a breast cancer diagnosis, we refer to genetic counseling, and they'll get blood work, which will then test to see if they have a gene mutation. If the patient has a gene mutation, their risk of getting another breast cancer in either breast can be as high as 60%. So that does sort of change your treatment discussion. Those patients may benefit from removing both their breasts to prevent getting another breast cancer, since the risk is so high. In patients who don't have a genetic predisposition but just have a strong family history and have gotten breast cancer, usually we don't. We believe that this is their event. This breast cancer is now. This is the time that they've gotten their breast cancer, and the chance of getting a second one is pretty unlikely.
Is there a link between breast, ovarian, prostate cancers? Are they all genetically linked?
Sure. So based on the gene mutation, patients with a BRCA1 or 2 mutation have a link with ovarian cancer. And we work with our GYN oncologists to figure out good timing to remove the ovaries, since unfortunately there is no screening test for that. And then there's other mutations such as PALB2 that definitely is linked with pancreatic cancer and prostate cancer.
Thank you for that. Another question that just came in. So you were talking about the different types of treatments, radiation, chemo, systemic therapy, risks or side effects on those. What are the sort of common ones of those treatments?
Sure. So in terms of radiation, one of the most common side effects is skin changes. You almost have like a burn, a sunburn to the skin, and so you can have peeling of the skin, and we use creams to sort of help with that. Once you've gone through the radiation, the skin is healed. Another side effect of radiation is fatigue, and it's more of a cumulative effect. So in the beginning, you may not notice it, but as those weeks go on into, week 3, 4, 5, patients are fatigued. They might feel like they want to go to bed earlier, they need a nap. And so that's definitely a real symptom that we see. In terms of the anti-estrogen pills, the main side effects there are sort of like repeating menopausal symptoms. So hot flashes, some patients have some joint pain. And chemotherapy, the common side effects will be hair loss, nausea, vomiting, and then things that need to be monitored in terms of their blood counts.
And okay, I'm just looking at this one. So if someone is diagnosed, what can they do to prepare themselves for breast cancer treatment, for any of this? Are there things that can shore up their immune system, help with nutrition, and what are the things that you're talking to your patients about?
Sure, and patients always ask them. It's sort of, they really need to feel as though they've taken on some control. A lot of patients feel like this is something that they did in their life to have gotten this, and that's really not the case. There's really not, a great link to. It's not like lung cancer and smoking. So it's nothing that anyone's done wrong. This is really something, unfortunately, that's more common, and just by being female and having estrogen. So in terms of, going through the treatment, staying well rested, staying hydrated, eating well is helpful. But what's more important is after you've gone through all the treatment, how do you prevent recurrence? And we know that a low-fat diet, limited alcohol consumption, and exercise are really the best things that can help with decreasing your chance of recurrence. Exercise meaning, going even just for like a vigorous walk 3 days a week.
Okay. There's another question that just came in that has to do with soy and the link, because there's a lot of discussion or a lot of reporting on sort of the soy can mimic estrogen. Is that something that normal healthy people should avoid, or people with breast cancer should avoid? What's your thoughts on?
Yeah, I mean, so there definitely is a lot of talk about that. There's no really strong data to say that you need to avoid soy. And so what we typically recommend is even patients who had breast cancer who might be at an increased risk is, take everything in sort of like a limited amount, right? I wouldn't eliminate it from your diet, but I don't know that I would like only be using soy products. There's not a strong enough link for us to say that it needs to be avoided.
Okay, that's interesting. And then the last question that I have, someone wants to know, so once you've operated on a patient, you've met with them, you've given them this plan, you go through a surgery and treatment protocol, how long does that patient stay with you? How long are you seeing that patient?
Yeah, so I follow my patients for at least 5 years post-operatively. So we really develop a strong relationship. I sort of enjoy seeing them at those later visits once they're 2 or 3 years out, and we space out the visits. It's not so much they go from seeing me maybe every 2 weeks to every 3 months to every 6 months, and then at the end I'm doing like an annual visit once a year with their mammogram, and they want to show me pictures of their children or their grandchildren and these people who went through such a horrible time, and I really am so happy to see how their life has completely continued on and they're doing great. And those are really my favorite survivorship meetings and visits. So I like that relationship that I build with them.
Well, thank you so much for that. That is my last question from our audience. And again, let me thank you on behalf of everyone at St. John's for your participation today. It's been really great. I do think we have a couple of announcements.
Sure.
Are we moving that forward? Okay, so this particular webinar was part of our month-long celebration of Breast Cancer Awareness Month, and we call it MammoFest. We do a celebration next week for anybody out in the community who would like to participate. Wear pink on the 27th, take your picture, send it in to us at info@riversidehealth.org, and we will put you on our social media. We are also selling all kinds of pink related items in our lobbies coming up. So please help us support the fight, and everybody should go out there and make that appointment for their mammogram. What else do we have here? Next. Yeah, book your mammogram today. And by the way, as Dr. McEvoy talked about, we do have tomosynthesis at both of our sites, 3D mammography suites at both Andrews Pavilion and Dobbs Ferry Pavilion. That is the number that you call on your screen for your appointment, 964-4329. And finally, we all know that everyone does have a level of discomfort about hospital visits and accessing care through the COVID pandemic. And so we did implement virtual urgent care. And if you have any questions or concerns, or even feel like you want to get an opinion before you make an appointment or come in, feel free to call our virtual urgent care number, 964-4429. And is that? And so again, general questions, you can call our main number. You can reach us at info@riversidehealth.org. If you need a physician or physician referral, Dr. McEvoy can certainly be contacted through physician referral, and that number is 964-4DOC, and that's 964-4362. Or you can email findadoc@riversidehealth.org. And again, thank you, Dr. McEvoy. Thank you, my team, for doing such a great job. And you can find this recorded webinar on all of our social media sites. So when you see it, please share it. Thank you.